All right. Well, good afternoon, everyone, and welcome. We'll get started right now. Welcome to the first in a series of 3 webinars that we're hoping will introduce you all to diagnosis as a fundamental component of patient safety, and tell you a little bit about what safe, high-quality diagnostic care looks like. My name is John Liptillion. I'm a program manager here at Leapfrog. And just a quick housekeeping note before we get started, we will have the slides and a recording available on the Town Hall Calls webpage after this presentation. So our plan for today is to take you through the basics so we can all better understand what we mean when we call something a diagnostic error, why Leapfrog and the Gordon Betty Moore Foundation that fund this work are so energized to take this on. So I said it was a series of 3. So next month, Dr. Hardeep Singh will review 2 new and I think actually really compelling resources for hospitals that are looking to get started on diagnosis. And then finally in November, we will have a couple hospital leaders on to tell you about the work they've done so far in this area. But so back to today. So I've had the good fortune of being able to present with Dr. Mark Graber several times over the last couple of years. We've been working together on this initiative, and I'm deeply honored to share the stage with him again today. Dr. Graber is the founder and the President Emeritus of the Society to Improve Diagnosis in Medicine, SIDM, and he's widely published in the field, and I think really the best possible person to give this talk today. Mark, I don't know if you want to say a few words of introduction.
Yeah, thanks, Jean-Luc. Welcome, everybody. Thanks for your interest in diagnosis. We'll be interested to tell you what we know about this.
All right. So just a couple kind of webinar housekeeping notes before we get into it. So as I said, we'll make the slides and recording available to you all after the presentation. So that's on that Town Hall Calls webpage, the same webpage that you might have used to sign up. So if you would please use the chat function for any kind of technical issues you might have, like if the audio cuts out or the slides aren't advancing. But then for like the content related questions or questions about the presentation material and so on, please use that Q&A function. So that'll help us keep a little bit better track of your questions and how we've responded to them. And so in case you had any questions about that, there's the slide here shows where the Q&A icon is on your screen. And I should say too, after the presentation, we'll have a live Q&A session where we'll walk through some questions in the chat, but we'll also you can use that raise hand icon at the bottom of your screen that'll let us know that you want to verbally ask a question. So when it's your turn, we'll prompt you to unmute yourself, and you can go ahead and ask. Before we get into it here, just a few sort of learning objectives to keep in mind for today. So first, what are diagnostic errors? What kind of an impact do they have on U.S. hospitals? Why are we talking about this? But then going a little bit deeper, what's behind diagnostic errors? What are those root causes? And then finally, to bring it all together in the Leapfrog context, how can we use quality measures and public reporting to advance accurate and timely diagnoses at hospitals nationwide? And with that, I'll turn it over to Mark.
Thanks, Jean-Luc. I'd like to start off by defining what we mean when we say there's a diagnostic error and review some of the data on the incidence and the impact of these cases. This is the definition we'll be using in our project: an event where one or both of the following occurred with harm or high potential of harm to the patient. The diagnosis is delayed or wrong or missed altogether. There is at least one missed opportunity to pursue or identify an accurate and timely diagnosis based on the information that existed at the time. And the National Academy added a second component to the definition about communication. So here it is. Accurate diagnosis was available, but was not effectively communicated to the patient or to the family. So it's a 2-part definition of error. We've learned a great deal about the likelihood of diagnostic error over the past few years, unfortunately. First, we know that diagnostic errors are common. There have been many studies using autopsies, chart reviews, standardized patients. And from these, we know that roughly 1 in 10 diagnoses is wrong or missed. And this adds up to over 12 million cases a year just in primary care. Many of these are inconsequential, but a small fraction are serious. And if you look at all the malpractice cases in the US today, diagnostic errors make up the #1 cause of high severity claim cases by a long shot. 2/3 of these cases involve death or permanent disability, and the aggregate cost at a national level is more than $100 billion a year. With each new research study that comes out on the size of the problem, it becomes ever more clear that diagnostic errors are responsible for a lot more harm than the other patient safety of concerns we've been focused on over the past decade or two. This is from ECRI, who concluded that diagnostic errors were the #1 patient safety concern in 2020, and it's been on their top 10 list several times in the last 5 years. The National Academy of Medicine issued a landmark report on diagnostic error in 2015. It summarized everything we know about the problem. The title was Improving Diagnosis in Healthcare, and this was the report's conclusion about the magnitude of the problem. It is likely that most of us will experience at least one diagnostic error in our lifetime, sometimes with devastating consequences. This is from a systematic review of diagnostic error in the emergency department, published last year by ARC. And we know that diagnosis in the ER is especially challenging for many different reasons, and mistakes in this setting can be dangerous. This study concluded that over 300,000 individuals every year will suffer permanent disability or die from diagnostic errors in the ER setting. If we do the math on that and divide by the 5,000 hospitals in the country, it would mean that at your hospital, 50 to 100 patients will experience serious harm in your emergency room every year. We've also learned a great deal about why diagnostic errors happen, what makes them likely. Let's go to the next slide. This was from a study by Gordy Schiff at Brigham and Women's Hospital. Gordy collected 583 cases of diagnostic errors, and he was interested in where things break down in the diagnostic process. And you can see that we're really not perfect anywhere. 20% of the time, the key problem involves just taking the history or completing the physical exam. But most of the problems seem to be in the middle, where you are trying to put everything together to synthesize all the available information, order the right tests and consults, come up with the correct set of diagnostic possibilities. So adding these middle elements together, 76% of the time, there's some problem with the clinical reasoning process that we use to come up with the diagnosis. And this is a bit of an oversight about why clinical reasoning is so challenging. In the first place, there's over 10,000 diseases, but there's only 200 symptoms. And on top of that, in medical school and residency training, the average doctor will only learn somewhere between 500 and 1,000 of these. And on top of that, there's complexity and variability in terms of the case, the patient, the clinician, and the healthcare setting. So the same disease in 5 different patients could present in 5 different ways. And we all know that our healthcare systems are getting more complicated every year, and it is not good news on the physician side of things either. Our training and our experience is idiosyncratic, so whether or not you get the correct diagnosis may depend a lot on whom you see, how much sleep they've had the night before, and many other variables that can all impact on the ability of the clinician to come up with an accurate and a timely diagnosis. I hope you are all starting to think about doing more root cause analyses of diagnostic error cases. And here's the approach that I recommend. Along the bottom, you can see the patient going along their clinical course. And at the little red star, that's the diagnostic error. So to understand these requires a very careful consideration of first the blunt end, the healthcare system, and how this impacts the diagnostic process. But we also need to consider what goes wrong on the cognitive side of things. Was it a problem with the history or the physical exam, or what went wrong in the clinical reasoning process? We are working on a handbook for how to conduct RCAs of diagnostic error with Leapfrog as we speak, and we hope to have this ready for you this time next year. We'd like to briefly review 2 cases of diagnostic error to give you a better sense of what we're talking about. Jean-Luc, you want to do these or should I?
Why don't you go ahead, Mark?
Sure. So the first case is that of Julia Berg. Julia was a 15-year-old girl who was really in perfect health, but came down with an acute illness. She had a sore throat, she had a fever, didn't have any energy. Some lab tests were done and she had elevated liver function tests. She had an elevated bilirubin. There was some worry that she had a cholestatic picture, and she had a CAT scan done, which showed gallbladder inflammation. And so that was the leading diagnosis, that she had cholecystitis and that she needed to have her gallbladder removed. She was admitted for surgery to remove the gallbladder. It went fine, but after returning to her hospital room, her blood pressure dropped out, her heart rate increased dramatically, and she had pain radiating from her chest pretty much everywhere. This is a quote from her family. "I tried to point out that the monitors to a nurse, but the nurse dismissed me and said that it's not my business to check the monitors," her mother said. "So I just kept reassuring Julia that everything would be okay." But nearly immediately, Julia coded. The mother, whose name was Welcome, was pulled out of the room. Dan, the father, was left to pick up after their other daughter was called back and found a crowd outside Julia's room. And 4 hours later, Julia had died. On autopsy, it was found that her gallbladder really wasn't the major problem. And the diagnosis, which should have been made much earlier, was really Epstein-Barr virus infection, mononucleosis, which is very common, as everybody knows, in teenage kids. Although the urgent care clinic had recommended a follow-up test for mononucleosis, the test had never been done. So this is an especially tragic diagnostic error, a case of mononucleosis that was misdiagnosed as cholecystitis, turned out to be fatal. The next case is that of Alex Jane. Alex was a 19-year-old college student, a runner, collapsed on a training run. And this is a quote from his parents. "I suggested that we compare his initial EKG results to a baseline EKG he had done with the Air Force ROTC a few months before, but his cardiologist didn't do the assessment." John remembers, if the hospital had done the comparison, they would have seen that his EKG had changed. The other thing I noticed was that he had a low potassium, but it was just barely below the threshold, and his doctors weren't concerned. Alex's initial potassium level was 3.4, just 0.2 points below the normal level of 3.6. Following this study, Alex was sent home with no further instructions, including not to keep running, even though such instructions appeared in his medical records. During his follow-up visit 5 days later, he was given a clean bill of health by a doctor in training. I think that means a resident. But 2 weeks after that, Alex collapsed during a solo run and died. The cause of death was sudden cardiac death due to long QT syndrome, a disorder of the heart's electrical activity that causes life-threatening arrhythmias that have been discussed in the medical literature since the 1980s. Alex had the acquired form due to potassium depletion, which is not uncommon in young men in hot, stressful exercise environments. So just to summarize where we're at, diagnostic error is a big, big problem. Everyone is at risk. And with just a few notable exceptions, hospitals are not taking steps to address this problem. No one has told them they have to. It is not a requirement for credentialing, and the Joint Commission has been distressingly silent on this issue. So the usual factors that motivate hospitals are not there. And even for hospitals that do want to get started, it isn't clear where to start or how to measure. And that gets us to the purpose of this Leapfrog initiative, which is to promote diagnostic excellence throughout the hospital setting, including the emergency room. And what we mean by diagnostic excellence is shown here. Diagnosis is accurate, it's timely, it uses the fewest resources, and it maximizes the patient experience. And we know that acknowledging uncertainty is a big part of this, and watchful waiting is certainly appropriate in many cases. But what makes the current situation especially frustrating for some of us is that there are many, many interventions that have been proposed and that are likely to improve diagnosis if they were used more widely. And most of these are not expensive or difficult to implement. Things like improving teamwork, improving follow-up, closing the loop on incidental findings, and using decision support. All of these could have a big impact. And I think this is my last slide. This is what we'd like to see going forward, where hospitals become learning organizations. So that's the little graphic on the right. We'd like to see hospitals begin to collect their own data on diagnostic errors in their systems, study why they're happening, where they're happening, and take steps to target these issues. In olden times, diagnosis was considered a very personal thing, the responsibility of the doctor. The organization didn't have to worry about it too much. But it's very clear at this point in time that diagnosis is very much a process that takes place in a socio-technical system. And that's the image on the left. So certainly the doctor's in the middle of things, but whether the diagnosis is correct and timely is going to depend on their environment, the resources available to them, the culture of the organization, and many, many other system-dependent properties. So in this framework, improving diagnosis is very clearly an organizational responsibility, and progress will require that organizations work with their clinical staff to begin addressing this very large and very important problem. Thank you.
All right, thanks, Mark. So I'm going to tell you all a little bit about what Leapfrog has done so far in this area, and then give you a preview about what's coming down the pike for the 2024 hospital survey. So, so Mark has given you this great overview of diagnostic errors. This is an area that Leapfrog is kind of new to. So it was really just in 2021 that we got started with funding from the Gordon and Betty Moore Foundation to launch the Recognizing Excellence in Diagnosis program. We convened an advisory group of the preeminent researchers, clinicians, purchasers, and even patients and their family caregivers who had experience with and expertise in this area. So far we've published a report describing 29 different options we call recommended practices for hospitals looking to reduce diagnostic errors. I'll tell you more about that in a minute. But we also measured implementation of these practices by surveying 95 hospitals across the country. So collecting both survey data from them, but also doing a variety of follow-on interviews, in group settings and individually to get at that kind of qualitative aspect of what they were doing. And now this fall, we're translating all of that research into practice. We're going to add new questions to the 2024 hospital survey to assess implementation of a select few of those recommended practices. So I should say, as always, when we add new questions to the hospital survey, these are not going to be scored and the responses will not be publicly reported. Instead, we'll do what we do with new sections and use your survey responses in that first year as a fact-finding opportunity to help us better understand how to set a fair standard in this area and what questions are appropriate to carry forward into a scored and publicly reported survey. So now, of course, we'll have many opportunities to give us feedback through the help desk and through our public comment process. Really the right way to think of this, I think, is that this is the first of many steps before we move to formally scoring public and public reporting of diagnosis. So I'm going to tell you a little bit about our project so far. So we started with, with really literally hundreds of possible interventions to reduce diagnostic errors. Now, some of these were suggested by our own advisory group, but mostly they were drawn actually from a review of the literature and existing measures and strategies. As Mark said, there are any number of different proposals out there for techniques, for resources, for strategies to use to reduce diagnostic errors. We also conducted a variety of key informant interviews with different experts to solicit some ideas. But with the help of our advisory group, we narrowed that down to 29 recommended practices. So this is really oriented towards giving hospitals and participants in the survey a menu of options to choose from. So the signature piece here of what we've published in the project so far is our recommended practices report, which includes, for all 29 of those practices, a statement of the practice, a rationale for including it with citations where appropriate, and then resources and strategies for implementation. So now usually we're citing a real-world published example of a hospital successfully implementing that practice. And then for several practices, we also featured what we call featured implementation examples. So this is a little vignette interview with someone who has led the implementation of a given practice and serves as kind of color commentary. So here's a little excerpt for what the report, just to show you what it looks like. This is a practice that's really important to me, promoting teamwork. So you have our statement there on the left, the rationale up top with a couple citations of how teamwork applies to diagnosis, and then some resources, some examples of how hospitals can apply this practice in the real world. But I wanted to take a few minutes to review some other example practices that we identified. These are in the domain of hospital leadership and systems, so sort of that social technical system that Mark was talking about. So practices that apply sort of hospital-wide or at a system-wide level. So we're looking for hospitals to convene multidisciplinary teams to identify, to analyze, and learn from diagnostic errors to avoid repeating them. We think that when the CEO of the hospital publicly signals that diagnostic excellence is a priority to the staff, that sends a very powerful signal and is often the first step that can trigger a kind of cascade of meaningful change. And we want to see strong two-way communication. So hospitals should disclose diagnostic errors to patients, but then on the other hand, patients should have pathways to report potential diagnostic errors to the hospital, to the clinician, and to know that they are being heard and that the hospital is taking action to follow up. So then turning to the diagnostic process itself, we have, this is the second domain of practices that we identify with opportunities for improvement. So in a lot of cases, it's as simple as providing the expertise that you need. So maybe that's a medical interpreter, radiologists, stroke specialists, or the kinds of specific clinical expertise that can help make a diagnostic determination. We also want hospitals to facilitate the joint review of diagnostic discrepancies. So with both radiologists and pathologists, reviewing potentially discrepant cases, but then also providing pathways to get second opinions where those are needed. And then finally, when patients are discharged from the hospital, if they have pending test results or if there's some kind of other loop to close with them, making sure that the hospital, to the extent possible, closes the loop on communicating those results to patients and to their, to the ordering provider maybe, or whoever is responsible and can work together to take timely action on that diagnostic test result. So before we move on to the Q&A for today, just a couple kind of quick notes for you on resources you can look out for if you're looking to get started. So first, the Agency for Healthcare Research and Quality, AHRQ, has published many white papers that drill down on specific topics in diagnosis and offer strategies on how to address those issues. They've also published a couple tools to measure your progress, namely Measure DX. So those are Hardeep Singh on the next webinar in the series will review those tools. And then as Mark alluded to, Leapfrog has been hard at work here too. So we've been working together with CITM and Mark himself on a couple different projects to publish resources for hospitals. So the first of those that we expect to publish by the end of the year is the PFAC Playbook. So it's a tool for patient and family caregiver advisory councils, PFACs, to help them co-create diagnostic excellence at their hospitals. And then next year, we'll have published a handbook on how to conduct root cause analyses, but with a specific focus on diagnosis. So as I said, both of those resources are co-created with CITM, the Society to Improve Diagnosis in Medicine, and with Mark. So with that, we do have one question in the chat that I'll just go ahead and address, but in the interim, please feel free to either raise your hand and we'll unmute you. You can ask your question live, or if you'd prefer to use the chat Q&A, we will answer those questions there. And at first, let's work on questions that are specifically related to diagnosis, Leapfrog's plans for diagnosis. We'll work on those. So the question in the chat, Kristen asks, generally, how many survey cycles until new questions like these are scored and publicly reported? So that's an excellent question. And like all good questions, it's hard to answer because it varies really based on the topic area and on the kinds of information that we get back from hospitals. So just to give you maybe a few kind of contemporary examples of this from section 1, where we have a few new sections, right? So we have a new section on billing ethics, a new section on health equity, and a new section on informed consent. So now the billing ethics section had 1 year as an optional section that wasn't scored or publicly reported before we moved to scoring and publicly reporting in its second year on the survey. Informed consent went through the same process. So it was optional. It was not scored or publicly reported in its first year. And then this past year for the 2023 hospital survey, it has been scored or and publicly reported. Health equity, however, is not yet scored or publicly reported. And although the section is required this year, so it's no longer optional, but we haven't moved towards scoring and publicly reporting that because we're still in the process of gathering feedback from hospitals, in our public comment process, in our piloting process, and just from the responses to try and figure out the right way to start to publicly report those data in a way that's useful for our constituency, purchasers and consumers, but that's also fair, to hospitals that are reporting to us. So all this to say, thinking then about how that would apply to the diagnosis section specifically, at this stage, honestly, I think it's too soon to say. It could be 1 year, it could be more, and that really depends on what we hear back from you all who are taking the survey, from the public, and so on. So we're definitely open to ideas, and we'll be taking a very close look at the data as we get those. So the next question is from Paul, who asks, is there a number of years of practice or level of training associated with diagnostic errors? And I wonder, Mark, if you have a view on that.
Yeah, that's a great question. And unfortunately, we do not have good data to answer that. There's some evidence that the oldest clinicians over 60 or 70 years old may make more diagnostic errors. But other than that, we really don't understand how it breaks out according to your years of training or practice.
All right, thanks, Paul. So Andrew Liu asks, how long does it take for these questions to become part of the Leapfrog safety grade as opposed to scored and publicly reported on the survey? So that's a great question. And now here again, it's a little bit different. So I'll say two things about that. So one, returning back maybe to those examples of those new sections I gave. So for example, billing ethics and informed consent. So now these are scored and publicly reported on the survey, but they aren't part of the safety grade. And we don't expect them to be, because the Leapfrog Hospital safety grade is really quite a different philosophical construct from the hospital survey, right? The safety grade is hyper-focused on patient safety specifically. So billing ethics and informed consent are, those are sections I work on. They're really important to me, but they are not specific to patient safety, so that they won't be on the grade. So now thinking in terms of diagnosis and what we expect there too, diagnosis is much closer to patient safety, obviously. That said, the process for going into the grade, that's some ways down the line, right? There's an expert panel that helps us with the measures on the safety grade. There are a lot of kinds of considerations that go into that. Those measures would have to be scored and publicly reported first. So, this in terms of your expectations about the sequence, they would be optional in the 2024 survey, non-scored or publicly reported. Perhaps scored and publicly reported in 2025, sooner, and then at some point maybe integrate into the safety grade. And maybe that's some. So we'll ask several questions about to calculate a few different measures of diagnostic safety and quality, and maybe that some do belong on the safety grade and others don't. So it's not necessarily that all of them will go in. All this to say that the safety grade is sort of the final stage and may not apply to all the measures here. But thank you, Andrew, for your question. So Judy asks, and Margaret, I think this is a good question for you. How do you integrate this work into existing processes such as mortality review, RCAs, et cetera? It's such a hard process to evaluate someone's decision making after the fact.
Yeah, thanks, Judy. So certainly there are things that organizations are doing already that would help in terms of improving diagnosis and performing RCAs on cases of diagnostic error would be the obvious place to start. The problem with RCAs right now, when most people get to the clinician level, they just stop there. They say, oh, it's human error, and they don't look into it any further. And what we're hoping is that organizations can get past that and start to think about why things break down in terms of the clinical reasoning process. There's a famous paper by George Bordage, and the title of it is, "Why did I miss the diagnosis?" And his answer is, well, I just didn't think of it. And that's so true in so many cases. But if you try and go a little bit further beyond that, why didn't you think of it? Was there too much work pressure that day? Were you fatigued? Were you distracted by something? Was the consultant you were going to run the case by not available? Are second opinions available? Are decision support resources available? So it's very appropriate to start looking at the cognitive aspects of diagnosis and to think about ways that the healthcare system can support that and improve it. We're also hoping that organizations will start doing some new things in terms of measurement, and I would suggest starting to look at timeliness. How long does it take in your organization for sepsis to be diagnosed, or aortic dissection, cases in chest pain in the emergency room headed in that direction? There are many, many things that can be looked at productively, and they would certainly start encouraging people to think more about how to improve all these processes.
All right, excellent. Thank you, Mark. So Kristen asks, is it possible to review the questions now that will be on the survey to begin conversations at our site? And so no, not quite, but soon. So we plan to release the new questions specific to diagnosis on the hospital survey. We'll release those with the proposed changes to the 2024 hospital survey. So that'll have the the full list of changes that we expect to make. So that gets released in November, in late November. So you can expect to be able to review those proposed changes then, and you'll have a few months lead time before the 2024 hospital survey goes live on April 1st of 2024. And then I think actually I'll also take in a question from Atrice asking, is this new measure for leapfrog going to take effect in January 2024? This is a related question. And so so we expect these new measures to be on the 2024 hospital survey, but that hospital survey is released on April 1st, 2024. So the 2024 hospital survey, the full cycle timeline there is the hospital is released on April 1st, 2024. We accept submissions all the way through November 30th of 2024, and then the cycle begins anew for 2025. So we'll have those measures on the 2024 survey, but they'll be optional, and they won't be scored or publicly reported. They're really for our fact finding to get a good sense of how hospitals are doing on those questions, to give us an opportunity to field questions about those survey questions on our Leapfrog help desk. We'll get a lot of inquiries asking for definitions of terms, asking if a given program that someone's implemented is consistent with the intent. Gives us an opportunity to reflect and to think about, to go back to our advisory group and our expert panel. All this to say, we have quite a bit of work left to do, not only in the lead up to the release of the questions shortly in November 2024, but then again throughout the 2024 hospital survey cycle to make revisions and updates to the questions that reflect the reality on the ground, the responses that we get from the hospital survey. So two questions from Stephanie. Any recommendations specific to measurement within academic health systems? And then the other question is also, most of these types of opportunities are identified within the peer review process. Some of this data able to be obtained, but blinded from peer review. I wonder, Mark, if you have any ideas about particularities for academic health systems and how peer review plays into all this.
Yeah, so thanks, Stephanie. We don't anticipate any questions on the survey that will be specific for academic health systems, but we do expect that academic health systems will be in the lead in terms of taking steps proactively to address diagnostic error. So this is certainly the kind of setting where you could look at supervision and handoffs and transitions of care and the interactions between clinicians and radiologists and laboratorians. So clearly in academic settings, the quality of diagnosis should be a primary concern. In terms of peer review, that's an interesting issue. And what we're hoping is that a lot of cases that used to go to peer review will be RCA'd instead. We think the just culture approach is perfect for this. If there's a diagnostic error where there was no intent to harm anybody, if it was inadvertence and the clinician really would have loved to make the right diagnosis but just didn't, that's not an issue for peer review. It's an issue for root cause analysis to see if there's anything in the process of care that might have been improved and would have avoided the diagnostic error.
All right, thanks, Mark. So Courtney asks, if a hospital is working on diagnostic error in a particular area, so for example, sepsis, would that count towards diagnostic error work in general? Well, so two thoughts about that. So one is that really the sort of headline response there is that it really will depend on what we're asking about. So obviously, the timely recognition of sepsis is a really important issue in diagnosis and patient safety more generally. So efforts in that area, depending on what we're asking, really well might work towards diagnosis in general, and that might be an effort you're doing there might be consistent with what we're looking for in the survey. That said, and again, we're talking about questions that aren't out yet, and a lot of the definitions will evolve as we work with you all through the questions. But it may be in some instances that some of the guiding philosophy behind this project is that we need to push a little bit further beyond sort of the existing set of what kind of work is happening in patient safety to reflect the urgency of the quality of care and diagnosis, and to address some things that haven't yet been addressed. So all this is generally speaking, sepsis is obviously a really important diagnostic issue. If you're working on sepsis, it sounds like a very valuable enterprise to me. But I wouldn't necessarily expect that all of your existing patient safety programs might necessarily fit into this new kind of paradigm in terms of what we're asking about. So our understanding from our pilot survey, from the research we've done, is that in a lot of cases we're asking for new work to address this issue, that new work that hasn't yet been done. So I hope that's helpful. And then Courtney is also asking, so timeliness is important, but somewhat controversial. Are there standard beginning and end times, arrival to ED, to administration of drugs, treatments, and are there benchmarks? So a timeliness benchmark. Well, Mark, I don't know if you want to talk about about those measures of timeliness, those stroke measures.
Yeah, thanks, Courtney. I think I mentioned there were probably 10,000 diseases, and we have timeliness guidelines for, I think, 3 of them: stroke, heart attacks, and sepsis. Other than that, we really don't have good guidelines on how long it should take to diagnose a particular condition. So what I'm kind of hoping is that organizations will pick a novel condition and look at what their timeliness is and why it takes them that particular length of time, and consider what they could do next year to shorten that interval.
Thanks, Mark. So Kristen asked, will Leapfrog be providing in their playbook guidelines or recommendations for those having difficult conversations with clinicians, so it doesn't feel punitive when diagnostic errors are identified, because that can impede the root cause analysis process? Mark, you want to talk a little bit about how we're thinking that would play into the RCA handbook?
Yeah, I think we definitely will include some guidance on that. It can feel awkward to talk about one's own diagnostic error, but once you get clinicians talking, what they'll realize is that everybody has had these experiences where they wish they would have made the correct diagnosis, or they wish they would have made the diagnosis earlier. So it's like a universal problem that we all face as clinicians, and it's pointless to try and keep these hidden. We need to start having these conversations, and yeah, it's going to be awkward at the start, but as you get used to it and you see that your colleagues are interested in this and they're having the same problems too, these can be very productive conversations. So yes, some guidance will be helpful and will be forthcoming.
All right, thanks, Mark. So question from Daniela here. So Daniela's asking, will the 2024 survey questions on diagnostic error be relevant for what's in place from 2023, or will it be for current processes in place during the 2024 survey? And so Danielle, I'm going to interpret your question to mean, although definitely please feel free to write in again if I've misunderstood you here. But in terms of the reporting period for the questions specific to diagnosis, so generally, when Leapfrog is asking about structure measures, in terms of what kinds of processes or structures your hospital has in place, we talked about different examples of those in this presentation. Often we are asking about something that's very timely, right? That's specific to the processes that you have currently in place during your as you submit the survey, and that's so that you have an opportunity to, once you've seen the questions and once you start to think about completing the survey, to make an update to how you do business to meet the expectations of the survey. So, and I would expect that this would be, largely true too for the questions about diagnosis. We are going to ask you about what things look like in your hospital, more or less in the present, right? It may be that we have process measures that have a retrospective look back and some other things like that, but the bulk of what we're interested in is what's currently happening at your hospital, and less so a retrospective view of the kinds of structures you might have had in place in the prior year. And I will say too, I think, as we think about the responses and sort of the timeline, it's never, as soon as you have the questions, and certainly at this stage already, you can start to look at our reports, or feel free to write to the help desk and schedule a call if you have questions about how you're approaching diagnosis and so on. It's never too soon to start, I guess, is what I'm trying to say. So even though we're talking to you now about changes that we have yet to specifically announce, we're hoping to hit the ground running with these, and to get a lot of great feedback from you all in that first year of administration in 2024. So we'll be really interested to hear about what your practices are currently like in 2024. And then Courtney asks, are there predictive analytics to assist with early identification and identified processes to help with diagnostic error? And maybe, Mark, you could talk about some of the strategies for identifying diagnostic errors.
Yeah, Jean-Luc, and we also have to give Courtney the prize for the best questions today. These are all terrific.
Thank you.
For sure, this is an extremely hot area. I think you've all seen the many publications that have come out over the past year or two on predictive analytics for sepsis recognition, and this is going to spread to other conditions. I would point out, however, that I think the most productive area right now is for organizations to think about providing decision support products that already exist and have been tried out. Things like Isabel or Visual DX or DXplain. These are off-the-shelf decision support systems that can help with differential diagnosis if you're not sure what the answer might be. And this is likely to be helpful. Hardeep Singh had a study where he looked at cases of diagnostic error. 80% of the time, there was no differential diagnosis in the medical record. So that's really the key step in diagnosis, is coming up with possibilities. And if what you have is not on that list, it's going to be very difficult to make that diagnosis in a timely fashion. So we'd like to see many more organizations use decision support. And as the years go by, for sure, there will be more and more of these analytic programs that we can take advantage of.
All right, excellent. Thank you, Mark. So Rhonda asks, the issue with diagnostic errors that you don't necessarily know it happens until an event occurs. If this is to be added to the survey, will it be serving evidence-based processes within hospital control, like communication of results, timeliness of results, or the review of adverse diagnostic related events? Well, so Ronnie, maybe you two can get a prize because I think you've laid it out exactly right. We absolutely want to be asking about processes and structures at your hospital that are within your control. So the and not not process measures where you don't really have any influence over the income or over the outcome, or process measures where you need to go well outside your hospital system to make the communication work. We think there are a lot of really good opportunities for improvement that are well within the hospital's control, and that are measurable as structures and processes. And really, that's a point of view that we've had from jump, right, in this project. The bulk of diagnostic errors happen in the ambulatory care setting. They don't happen in hospitals. It's not to say there isn't plenty of work to do in hospitals, but most of the quality and safety issues with diagnosis are happening outside of your hospital's control. And I think that's maybe what your question is speaking to. We absolutely understand that. But Leapfrog's relationship is with hospitals and surgery centers. In this case, specific to hospitals, because that's really where diagnosis is. And we're going to, very intentionally in this project and the research we've done and the experts we've spoken to in the pilot that we've done with 95 hospitals, and in the report that we published, we've absolutely focused on processes and structures that are firmly within the hospital's control. So many of the interventions that we discarded, we talked about the universe of 100 different, or really hundreds of different interventions, to narrow it down to 29 practices. A lot of what was discarded is just things where we couldn't really hold a hospital accountable for whether or not that process or structure happened, because it just wasn't in their control. So I think the list that we're left with, these 29, and then a still narrower list of what will actually appear on the survey, I expect you'll be pleased to see that these are definitely things that are within your control, that have a great evidence base, and that have a real impact on the safety and quality of care, specific to diagnosis. And then just a question about whether the slides and recording will be available. So yes. So actually, if you scroll all the way up, I answered one of those questions with a link. But so they'll be on the town hall calls page. So it's actually probably the same webpage that you used to sign up for this webinar. You'll be able to find them in the same place. If you scroll down, there are other prior webinars where we've made the slides and recording available. So yes, so you'll be able to check those out. That said, certainly if you have if we weren't able to get to your question today, or you download the slides, listen to the recording again, you have a follow-up question, you shouldn't hesitate to reach out to the help desk, either just to return a question or to schedule a call with me or one of our experts. We'd be really happy to talk to you about, about your feelings about, this new standard. If you've had a chance to take a look at the report or some of those other resources we've mentioned, we're really interested in your feedback as we mold and shape these new questions on diagnosis. And so now I don't see any other questions here in the Q&A, but we do have about 5 minutes left. So we did also prepare a couple discussion questions. You can feel free to write, just to write in your answers in the Q&A, or raise your hand and we'll get to you. But two actually pretty closely related questions, really just, have you had an opportunity to engage with some of the resources that we put out so far? So the report, or any of those ARC resources, or CIDM, of course, has published a wealth of resources here. Have you had an opportunity to engage with them, and did you find them useful? And then sort of the other side of that coin is, what other information do you need to help launch your hospital on a path towards diagnostic excellence? So if you have any thoughts about either your experience with the published resources so far, or something that an answer to a question you couldn't find that we can provide. Mark and I talked a little bit about the PFAC playbook we're hoping to publish soon, the RCA toolkit. So we're hoping that both of those resources are timely and will address some important gap areas in what's currently available. But then from there, we can always do more work to provide more resources for folks looking to get started. So if you have a thought about that, please write in or raise your hand and say it out loud. All right, well, I don't see any responses quite yet. I don't want to force the point, but by all means, if you have any, if you need a minute to think about these and you have any reactions, again, please feel free to write into the help desk. So we have 2 more webinars scheduled in this series. So on October 18th, at the same time, 3 or 4 p.m., Dr. Hardeep Singh will take you through a couple different really important resources that can serve as a sort of foundational resource as you think about how to get started here. So that's the Safer DX checklist and Measure DX. So this is an ARC resource to identify, analyze, and learn from diagnostic safety events. And finally, the 3rd webinar in the series. So here, honestly, we're really lucky to be able to be joined by Dr. Divi Upadhyay. He's at Geisinger, of course, and he'll present a little bit about how Geisinger has approached driving improvements in diagnostic safety and quality. And we're hoping to have another guest as well. And this session, really, we're hoping to conclude with, of course, questions and so on, but a real conversation too about how participants can leverage any kind of learnings from this webinar series or from other resources to kickstart improvement in their institutions. So with that, unless there are any questions about the webinar series, or at this point, since we're just a couple minutes from the end, if there are any other questions that we can answer about the survey or safety grade, I'd be happy to take a couple. But otherwise, that's the material we had for you today. All right, well, thanks so much, everyone, for joining, and it's been really a pleasure to talk with you all. I loved the questions. I thought they were all excellent, and I'm really looking forward to these next few webinars, and then to sharing our work here and with the questions on the hospital survey. All right, that's all for today.